Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Our speaker tonight is Dr. Nate Lighthizer, who's a graduate of Pacific University's College of Optometry. He then completed a residency in family practice optometry with an emphasis in ocular disease and laser and surgical optometry through Northeastern State University's Oklahoma College of Optometry. He has served as the chief of specialty care clinics and chief of the electrodiagnostic clinic. Huge jump. In 2024, he was named Dean of the Oklahoma College of Optometry. Tremendous accomplishment. He's a founding member and currently serves as immediate past president of the Intrepid Eye Society, which is a group of emerging thought leaders in optometry. He lectures nationally and internationally on numerous topics, most notably advanced ophthalmic procedures, electrodiagnostics, and ocular disease. I can tell you from personal experience, Nate is a fantastic educator, a great person, a person who has advanced the profession dramatically in his short tenure as a professional. I'm very much looking forward to hearing everything that Nate has to say. He's one of the top minds and an excellent educator. So with that, Nate, please take over and tell us about optometric surgery procedures for every optometrist.
Thank you, Joe. I appreciate that all too kind introduction. Means the world to me coming from you. I appreciate the invite from Greg and Joe to do another webinar for them, an optometric education consultant. So, good evening, everybody. I hope you're doing well. My name is Nate Lighthizer, faculty member, and I serve as Dean of the Oklahoma College of Optometry. Really looking forward to talking for the next hour and 40 minutes on optometric surgical procedures and really having some back and forth with you guys. I know we're not in the same room or even the same state, but we're going to pause after a number of different videos that I'm going to show and get Joe's comments and Greg's comments and ask questions as we go back and forth on these procedures, whatever we talk about. I want to encourage you guys as optometry becomes more and more medical, whether it's from dry eye or macular degeneration or diabetic retinopathy or glaucoma or whatever it is, that we continue to think about how do we push the envelope and better help our patients. And we're going to talk about in-office procedures. All of these procedures that we talk about tonight are done in the office. They're not done in an OR, or they could be done in an OR, but they don't have to be done in an OR. They don't have to be done in an ASC. They are optometric surgical procedures or optometric in-office procedures that all of you could do should you so desire to do that, and your state obviously allows that as well. So here's my disclosures. We will keep this within the guidelines of a COPE approved lecture. Again, all relationships have been mitigated, and again, we'll keep this within the guidelines of a COPE approved lecture. Really, this is video grand rounds. I'm going to show nothing but videos over the next hour and a half, hour and 40 minutes on a variety of procedures. And I always start with this slide and say, which of these would you like to see? Which of these excites you the most? If you were able to do all of these procedures, which one would you adopt first? Which one would get you the excited the most? Which one would you do the most? And there's a ton of procedures listed up here. I do most, if not all, of these procedures, and some of them are more common and some of them are less common. I did this afternoon, I was in OD surgery clinic, optometry surgery clinic, and we did 3 or 4 eyelid lesion removals. I did a lid everting suture for entropion in an 86-year-old who her lower eyelid was turning in and she was miserable from that inward turning eyelid, that entropion. So there's a variety of different procedures. I was in laser clinic yesterday afternoon doing YAG capsulotomies and SLTs and laser float removal. So, as you digest this list, what gets you most excited? What would you like to see over the next hour and a half? And I have a polling. I always like to poll the audience. This is the only question I'm going to ask tonight. So don't confuse this with what Joe is going to post. This is just my for poll everywhere. Grab your phone. Okay, grab your phone and scan that QR code with your phone. Open the camera and scan that QR code. Okay, that will open up my poll everywhere page. You don't have to download anything. You don't have to sign up for anything. Okay, if they ask you to sign up for something, just hit skip for now. You will get your CE credits even if you don't do this. But I'm going to ask you, we have an opening question here. What procedure do you want to talk about? I'm going to go back just because I want everybody to have that opportunity for the QR code. scan that QR code. Again, not required, just a fun way to do one poll question at the start of this lecture. You guys are going to kind of dictate which path we go down for this lecture. What are you most interested in hearing about? What are you less interested in hearing about? So that's this opening poll here. Again, scan it with your camera on your phone. It opens up my poll everywhere page. We've already had, 21 of you that responds. And I've listed, 7 or 8 of the most common procedures that we do right in the office. Right in the office, these procedures. And again, we're going to go through the different states that authorize these procedures in just a little bit. But what interests you guys the most? Oh, great. We've already had 32 of you respond here. And again, you're going to choose the path. And what's cool is all right, look at this. Number one answer, eyelid lesion removal or biopsy. So, Joe, you can see these responses, correct?
I can.
All right, so we're going to start with eyelid lesion removal or biopsy. We're going to talk about YAG cap. That was number 2, laser floater removal. Number 3, SLT and treating trichiasis. Number 4. My goal is to get to all of these, over the next hour and 35 minutes so we can touch briefly and hopefully, interest you a little bit in all of these different procedures. So I always start with this slide.
Hey, Nate, are you able to hear me?
Yes.
Yeah, I want to just, as you recall, when you came out the PCO and I took the laser course and the surgical course, and I was going in to do the lasers and get all excited. Then I went and got my Oklahoma license. But you remember what I was always excited about? Doing the RF, removing the lesions. We were having fun doing all that. So that's kind of cool to see that the audience likes the eyelid lesions also. So that was pretty cool. So, all right, I'm done.
That's why I love this polling. So you guys can know individual answers, but you can see what kind of gets the group excited. And that's where we're going to start about in just a second here. So I always start with this slide. And then there were 3. And what do I mean by that? Well, I cut down to Oklahoma in 2009. One of the reasons that Dr. Blair Lonsberry, who was my mentor at Pacific University, I said, Blair, I really love the procedures aspect and the ocular disease. And he said, Nate, you got to go down to Oklahoma. In 2009, they were the first state to authorize optometrists to do laser procedures. The first laser was done by an optometrist in 1988. Hard to believe, 1988. It's been 38 years that optometrists have been doing laser procedures in Oklahoma. And Oklahoma was the only one for a long time. And when you're the only one, you're on an island by yourself. You're kind of the crazy one. 49 states did it this way, and Oklahoma did it this way. And throughout the 90s and 2000s and even the early 2010s, they were the only state that authorized laser procedures. But then there was state number 2. Anybody know who was state number 2 to match Oklahoma's law? The second state to get laser procedures, the ability to do YAG caps and SLT, PI. Anybody know who it was? Maybe via the chat box you can type it in, or Joe or Greg if you want to chime in. Who was state number 2? Anybody know?
I don't remember.
State number 2 is the state of Kentucky in 2011. They passed a law very similar to Oklahoma's law, and they were state number 2. All right, now we got 2 anomalies, 2 on an island, 2 crazies, and 48 do it the other way. But then there was a third state. And this third state, I think it was very, very key because now you're seeing a mini trend. In 2014, the state of Louisiana became the third state to authorize optometrists to perform laser procedures. And again, for a long time, there was one state, Oklahoma, and now in the span of 3 years, from 2011 to 2014, 2 more states have added. So then there were 3. State number 4 has actually the best law in the country. State number 4 is that it's not Oklahoma, it's not Kentucky, it's not Louisiana. State number 4 has the best law in the country. They passed their law in 2017. Why do they have the best law in the country? It is an as-taught law. They will never have to go back.
Alaska.
That is going to be Alaska. You got it, Greg. You got it. In 2017, they have an as-taught law in Alaska. They will never have to go back to the legislature again. They have 2 regulations there. If it is taught by an accredited optometry school, at least one accredited optometry school, and if the optometry board develops rules and regulations, not the government, not the legislature, if the optometry board develops rules and regs for X procedure or Y procedure, they can do that in the state of Alaska. So they have a law very similar to our MD colleagues and our OD colleagues as well, and our DO colleagues, I should say. And then there were five. Who was state number five? State number five was the state of Indiana in 2018. They actually did it a unique way in Indiana. They did not pass a law in Indiana. They reread their 1937 law or whatever year it was way back when, and they said, doesn't say we can't do it. We're going to start doing it in the state of Indiana. In 2018, they brought me up there and our team up there, and we trained them on lasers, and they've been doing laser procedures in Indiana for the last 8 years. We can now say, and then there were six. Who was the sixth state? Sixth state was Arkansas in March of 2019. And then there were seven. State number seven was Mississippi in March of 2021. State number eight was Wyoming in April of 2021. State number nine, Wisconsin in 2021. They did not pass a law. They went the Indiana route on this one. So that was Wisconsin in 2021. Doesn't say they can't do it. And they started doing it in 2021. And then there were 10, Virginia in March of 2022. And then there were 11, Colorado. The 12th state was South Dakota. The 13th state was Montana. And then the 14th state was the state of West Virginia. I will comment, you guys are one of the first groups to hear this. They have tied for the best law in the country. They also have an as-taught law in the state of West Virginia. So West Virginia and Alaska have the two best optometry laws in the nation. So remember that for maybe a future polling question that you're going to see here from Joe in just a little bit. How many laser states are there? The answer is 14. There's currently 14 states that authorize optometrists to perform laser procedures of some variety. And oh, by the way, there's even more states that authorize optometrists to do injections, eyelid procedures, though that lump and bump removal, that was your number one answer. There's even more states that authorize that. The answer is 20. I would remember that number as well. How many authorize lasers? 14. 14 states. How many authorize injections, eyelid procedures? The answer is 20. 20 states. So can you see a trend? I always go back, if I go back here. Guys, can you see a trend over the last 14 years? Over the last 15 years? Again, there was one state throughout the 90s and 2000s and early 2010s. And in the last 15 years, there has been 13 states that have been added to this list. So you see a clear trend. Just like diagnostic drops back in the 70s and 80s, and therapeutic eye drops in the 80s and 90s, and oral medications in the 90s and 2000s and 2010s. There's all 50 states can use diagnostic drops and therapeutic drops and oral medications. And I think at some point, who knows when, you're going to see state 20 and then 25 and then 30 and then 35 to authorize laser procedures. It may be 20 years from now, maybe less, maybe longer than that, but you can see a clear trend of more and more optometrists being able to do in-office procedures there. So moving on, let's talk on standard lesion removal. I love eyelid procedures. I love Tuesdays, which is my OD surgery clinic day. All day long, we were in optometry surgery clinic doing procedures. And, I always tell people, and Joe and Greg have heard me say this as well, you choose your patients wisely and you choose your procedures wisely. As you're doing these lump and bump removals, you're not going to start with a chalazion incision and curettage. That's going to be a little bit more than you can bite off on your first one. You're going to start with easy, with simple, little skin tag removal, papilloma, verruca, seborrheic keratosis, which are SKs, little cysts. You guys have seen these. We had one today, it was just an easy, perfect one for a student to do. They're like their first one or second one, a third-year student doing their first one, and it was a upper eyelid little verruca. A verruca, there's two lesions right next to each other, a verruca and a papilloma, and it was so easy and simple to remove. Now, you can remove these lesions in a lot of different ways. There's more than one way to skin a cat. There is, as the saying goes, there is more than one way to remove this little papilloma. I pause the video here. As you look at this little skin tag, this little papilloma, okay, it's as easy as it gets. You could remove that with a scalpel. You could remove that with a surgical scissors, little Westcott scissors and snip that. You could remove that with chemical cautery, the use of dichloroacetic acid, which I'm going to make sure I talk about tonight with that because that's an injection-free way to remove lesions. How about liquid nitrogen? I know you guys have heard of cryotherapy before. That's liquid nitrogen. That's another injection-free way to remove lesions. The number one way that we remove lesions is with radio frequency, something called the Elman unit. It used to be called the Elman unit when Greg took this course back in 2017 or 2018. We called it the Elman unit. They've changed the name now to the Sonoquence unit, but it's a radio frequency device. And it emits radio waves out of the probe. You're looking at the loop electrode, that little circular electrode, and it's going to vaporize these lesions layer by layer by layer until this is smooth and flush. And the beauty about radio frequency is you can cut and coagulate at the same time, which is just so nice. It helps to minimize bleeding. So this student here is removing their first one, and they're asking, right here, Dr. Nate, is that where I go? I'm like, yep, that's where you're right there. Yep, that's where you go. Okay. We're going to take this off right at the stalk, not too deep. Now, you don't have to pull the lesion off the patient's face before you remove it. I was joking. Yeah, they're tenting this up quite a bit, but right at the stalk, right at the base of the lesion, we cut right through that lesion. Okay, this is a fourth-year optometry student doing this one, one of their first lesion removals. And that was a cotton tip applicator soaked in sterile saline. And this is the beauty of radio frequency, is you can now make this look smooth and flush. Again, we're on setting number 1, which is cut. We are cutting through this tissue very gently, very precisely. That tip does not glow orange. That radio frequency heats up intracellular water, heats up the water inside of the cells that you are touching. And they just graze that lesion a little bit more. And now we wipe away the carbonized tissue, the loose tissue. And watch, here's the last pass here. There's a reason I show this video first, because this student did just a perfect job. There's minimal to no downward pressure. And look at that carbonized tissue. You wipe that away, and voila. You can't even tell a lesion was there anymore. No stitches, no sutures. Looks phenomenal. Looks great. That's as easy as it gets, guys. And again, could you remove that with a Westcott scissors? Absolutely. A scalpel? Absolutely. Chemical cautery? Absolutely. You can remove that with acid. That'd be an injection-free way. Lots of different ways that you can remove lesions. Here's another one. This is a patient with seborrheic keratosis, a bunch of little SKs. Okay, so let's add in that last one. We didn't video the injection. This one, you're going to see the actual injection. Okay, so we always start, there's an alcohol swab. You prep for the injection with an alcohol swab. Before you guys get poked with a needle in your shoulder, they do an alcohol swab, don't they? So you did alcohol swab, then we're injecting lidocaine here. Lidocaine with epinephrine. A little 30 gauge half-inch needle on a 1 cc or 3 cc syringe. A little poke, and a little burn. Okay, did a little local anesthesia. Local anesthesia. Little poke, little burn. I always call this step number 2. Step number 1 is an alcohol swab. Step number 2 is local anesthesia. Mrs. Jones, this is what you're going to feel the most. You're going to feel a little poke here. Here comes the poke. Hold still. There's the poke. And you may feel a little bit burn. We actually often buffer the lidocaine with sodium bicarb. I don't have time to get into that tonight, but that's sodium bicarb to make the lidocaine sting less. And you're just putting a little bolus of anesthetic around or underneath that lesion, and then you massage it in. Easy injection. A little 30 gauge. We typically, you're not seeing it here, but I'll have them keep their eyes closed for these injections. We do not do these lesion removals behind the slit lamp. So we don't do these behind the slit lamp. Patients like to do what when you're doing Goldman or gonio behind the slit lamp? Kind of pull back. Imagine if you're taking a needle towards them or a surgical scissors, so you want them laying flat or semi-flat. You could do this in a exam chair reclined back. We do this in a little minor procedures room that we have at our school. And we're just massaging this in. So that's, again, step number 2, local anesthesia. Step 3 is betadine. Okay, if you've ever had a surgery before, they're prepping the skin. We're knocking down the bacterial load to lessen the risk of infection. We're testing to make sure we're numb. Mrs. Jones, do you feel any pinching, sharpness, or pain? Any pinching, sharpness, or pain? You shouldn't. You might feel some pressure, but we're just confirming that they are numb before we touch them with the number one way that we remove lesions. This is what our student used today for that ideal upper middle of the upper eyelid lesion that we removed at 3 o'clock this afternoon. That's the what's called the bent tip or the pin electrode. We're still on setting number 1 cut. We are cutting through this lesion. A little touch. You know what the skill here is, folks? Can you touch the bump with the wire? Can you touch the bump with the wire? Touch. And you can see we're carbonizing this. We're vaporizing this layer by layer by layer. Remember, benign lesions originate in the epidermis and they bud out. These lesions originate in the epidermis. Scrub. Joe, we have any questions as people are watching this?
Not a question. Somebody said, amazing. Another person made a comment. They believe Minnesota now allows injections and lid lesion removals. Any comment, or are you are you aware?
I'm very, if I didn't have Minnesota on the list, it's because that was just strictly from omission. I will be traveling to Minnesota on Friday, Joe, where we are doing our surgical procedures course, the one that Greg referenced that he took in 2017, 2018. I will be in Minneapolis all weekend helping to train the docs because you are absolutely correct. They have injections and surgical procedures. They don't have laser. They didn't get lasers, but they got all of this eyelid stuff in Minnesota. So yes, they are ready to hit the ground running, and we'll be doing our 16-hour injections and eyelid procedures course in Minneapolis this weekend.
Hey, Nate, can you go over the you kind of hit it right there that these lesions are in the epidermis, they grow out.
Yep.
You taught me, and I want you to be the person that says it, is that if it's cancer, it's got enzymes that go down. Can you just
Yep.
kind of maybe just hit that highlight real quick?
Sure. Yeah. You can have cancerous stuff that originates in the epidermis as well, but how does cancer spread? Through blood vessels and lymphatics. There are no blood vessels or lymphatics in the epidermis. So it has to dive deep through those enzymes that he talked about to penetrate the basement membrane and get down into the deeper dermis where the blood vessels and lymphatics are located. So, knowing all that, you're still going to do your evaluation. You guys do this all the time. If you have a patient that comes in with an eyelid lesion or an ocular adnexa lesion, you guys are going to evaluate the risk that is this lesion benign or is this lesion malignant. I know all of you have heard of the ABCDEs. Asymmetry, and you're going to look for the borders and the color and the diameter and the evolution or the history. You're going to look for ulceration. You're going to look for lash loss. What's the appearance of the lesion? And you're going to evaluate and you're going to make a decision. Is this lesion likely benign, which, by the way, about 90% of eyelid lesions are benign based on the literature, or is this lesion basal cell or squamous cell or things like that? It's ulcerated with hair loss. I'm concerned about this one. Okay, I'm going to probably refer that one out. So my point is you guys are already making a decision when patients come in. Is this likely a benign lesion or is this likely a cancerous lesion? They can originate in the same spot, the epidermis, but they go in different directions. Benign lesions bud out, and cancerous lesions dive in through those enzymes to be able to spread if they are going to spread. So you're just watching us on the bend tip electrode here, removing this little SK. Here's another one. This is the beauty to me, Joe and Greg, of radio frequency, is lesions like this, where, you look at this, that's a little SK. It's a fairly flat lesion. It's not completely flat, but it's fairly flat. That would be hard to snip that with a scissors. Would any of you be a little nervous taking a scalpel and cutting and slicing to that? All you got to do is just barely touch this. And again, this is just going to melt away. We had one of these this afternoon as well, where the resident took an SK off of a lower eyelid, and it was just touch, and you vaporize this, and then you get your magic eraser. I call that the cotton tip applicator soaked in sterile saline. I call that the magic eraser. Because watch this. You know, they've touched this and touched this, and it's kind of carbonizing and it's vaporizing, and here comes the magic eraser. And watch this. You do this little scrub. You go, holy smokes, we removed most of that carbonized tissue here. And this lesion is 75, 80% gone. We're going to clean it up with the bent tip, maybe 90% gone. So that's the beauty of radio frequency. It just gives you so much flexibility to kind of work in this area. This bent tip electrode is by far the #1 electrode. And again, they're numb already. Why are they numb? Because we did local anesthesia. You guys watched that part of the video. That's step number 2, local anesthesia. And then you clean it with betadine, and then you remove the lesion after you test to make sure they're numb. Again, I take a final look after the students and the residents do these. And by the second part of by their 4th year and by the second half of their residency, they are just moving and grooving. They're just hitting the ground running. They're awesome. You said that thing is gone. So benign eyelid lesion removal. Let's do a couple of others here. Capillary hemangioma is one that this is easy. You guys ever have patients that have these strawberry hemangiomas, capillary hemangiomas, cherry hemangiomas? The beauty of these, okay, when you see this, you're going to treat that with a scalpel. If you cut into that, what's it going to do? It's going to bleed. So now I use radio frequency no longer in cut mode, but in coagulation mode. That's setting number 3. It's 90% coagulation and 10% cut. And I will take a little electrode, either the bent tip, which you just watched, or the ball electrode, and you touch, and you guys can see my cursor here, and you go touch, 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 and you turn this thing white, okay? You're coagulating the top part, and then you take your magic eraser and you scrub, and it's going to turn red again because you got the top half, but you didn't get the bottom half. So when you scrub away that top white tissue, you see the underlying red. So then you touch, 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 touch again. You take your bent tip of your ball and you touch, 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 round 2. And when you get all of these, they turn black. You have coagulated the entire capillary hemangioma. Okay, we're done at this point. There's no more red. We've turned it black. 2-week follow-up. There's what it looks like. This patient is thrilled. It's not fully healed yet, but it's mostly healed, and that capillary hemangioma is gone. So my point is this. You utilize your tools in different ways. Joe and Greg, both of them strike me as people that are very handy. They can probably fix a lot of things, obviously eyeballs, but many things as well. To do the right job, you got to have the right what? Got to have the right tool. So, and you're going to need multiple tools in your toolbox, and radio frequency allows you to cut, but for this lesion, it allows you to coagulate as well. Patient with a capillary hemangioma underneath the eyelid. Here's another patient of mine, big capillary hemangioma, wants this gone, and we can coagulate that with radio frequency. Some of the most common benign lesions that we remove are cysts. These are fun, simple, and amazing camera work in this video. Isn't this amazing camera work? I just love it. Sorry about that. We'll get the camera better here. Little injection. Again, little injection, local anesthesia. Massage it in. It's a very superficial injection. The needle is just going beneath the skin, just beneath that skin, the epidermis and dermis, just beneath that. And the eyelids hold fluid so very, very well. We're massaging that in. There's our betadine, okay? And again, there's lots of different ways that you could make a little baby incision into this cyst. Lots of different ways. You could take a scalpel. You could use the scissors and kind of just gently snip. Heck, you could even use the bevel of a needle if you wanted to just kind of slice and give yourself access. Here you see the bent tip electrode again. And we're on setting number 1, cut. We don't have to coagulate there. We're cutting into this lesion. Okay, cutting into this lesion to give ourselves access to this cyst of Zeiss, this sebaceous cyst. And once you have access,
was there epinephrine in that injection?
Yes. Yep. And we're going to use lidocaine, 0.5% or 1% or 2% with epinephrine, 1 to 100,000 or 1 to 200,000. So epinephrine is your friend. We use lidocaine with epinephrine. Epinephrine is your friend. What does epinephrine do for you? It constricts the blood vessels. Isn't that fun? Look at that cheese coming out. That is awesome. I could squeeze out cheese all day long. I know Greg could too. He loves that cheese, right, Greg?
Absolutely. Yep.
But yeah,
Hey,
epinephrine is your friend.
Nate, a question came out. How do you protect the cornea during these procedures?
Yeah, so a couple of answers. How do you protect the cornea? Number one, know what you're doing. Again, we're on the eyelids, and typically, this video is a number of years old. I would probably have the patient close their eyes. If you can have them close their eyes, now in this case, the upper eyelid would get a little bit in the way, but if you pull the lower lid down, I could keep their eyes mostly closed and do this with their eyes mostly closed, and that would protect the cornea. The other option would be put a corneal shield on there. And you could put a corneal shield on. Do I usually use a corneal shield? No. No, no, I do not. But it certainly would not be wrong to do that either. So lots of different ways that you can do that.
You can actually see the little blanching there. That's why I asked if there was epinephrine. You can kind of see that little blanching of those
Yep.
lids.
Minimizes bleeding and it keeps the anesthetic around longer. Anesthetic wears off quicker when you don't have epinephrine because there's more blood flow to carry away the lidocaine quicker. So, yeah, that's just a quick cyst removal, cyst drainage. Let me show you another one here. These guys come in. This is what we do all day Tuesday. And you think this patient wants these gone? Yeah. And we're going to document a functional complaint. People often ask about billing. How do you bill this? Is it cash pay? We document a functional complaint. Doc, this itches. I pick at it. It's irritating, whatever it is. This one actually is in his line of sight. You could see this cyst here. So let's watch another quick video, and then we'll move on to YAG capsulotomies after this one. This is students doing this one. And this one shows a little bit of the learning curve on this. Certainly there's a learning curve to all of this stuff. Student was just practicing there, just touching that nothing was active on the foot pedal there. There's a learning curve to this stuff just like there is anything else. Are you better at corneal foreign body removals today compared to your first one? I bet you are. It's an easy, simple little lesion there, little papilloma. Again, it's already been numbed up. So you've missed step one, the alcohol swab. You've missed step two, the local anesthesia. You can see the betadine residue. And the student is cutting through this lesion, vaporizing layer by layer by layer. And they're going fairly slow because it's probably their second or third or fourth lesion removal during their fourth year. And again, you can see how nothing's active right now. They're kind of practicing, and you'll see when it's active. You can see the little plume of electrosurgical smoke. You can see that little plume of electrosurgical smoke. You're going to have a smoke evacuator right next to this. Otherwise, the patient will go, what stinks? You do, as we're burning this lesion away with these radio waves. Again, easy. This is as easy as it gets. This is what you start with. And, you do a handful of these. Maybe it's 5, maybe it's 10, whatever it is, based on your comfort level to get, all right, I'm comfortable and confident in removing these lesions. So, little baby skin tag removal. Let's get to the fun one here in just a second. That great big cyst. Again, this is a fourth-year student at the very start of their fourth year doing this procedure. And the eyelids heal incredibly well. I had an oculoplastic surgeon tell me a number of years ago, the eyelids heal almost in spite of what you do to it. All right, watch this. Here, look at this. We're going to make an incision. Look at that. Well, yep, we've given ourselves access to the cyst. Look at that cheese coming out there. And once you've given yourself access, you are going to squeeze with a cotton tip applicator, 2 cotton tip applicators if you wanted to, a forceps. This is the #1 forceps that we use coming in right there. The 0.12 millimeter toothed forceps. It's got little teeth on there to grab tissue. What's the size of the teeth? 0.12 millimeters, 0.12 millimeters. Toothed forceps, and you squeeze and you drain as much of that cheese as possible. Now, this is where the learning curve comes in because when it's pretty easy to make a little incision, Like you said, you just basically touch the top of the cyst and you make a little incision. And it's pretty easy to just kind of squeeze the cheese out, but then you need to go what I call capsule hunting. You want to make sure you get the sac, the capsule, the lining, whatever you want to call it, the lining of the cyst, the capsule of the cyst, the sac there. You want to make sure that you get all of that. And this is the student doing this one. And again, I always take a final look. So student was, all right, I'm good. And they removed the other lesion that was right next door to it right here. And then this is me coming back at the end going, now we still got a little bit of stuff in there, a little bit of cheese. But watch this. This is a great video. You use your forceps. Watch this. Here comes see that right there. Look at the lining of that cyst. You want to make sure you get any white lining. You want to pull that out. You want to tease that out. Sometimes you can tease this out pretty good, and sometimes you got to kind of get a forceps and a scissors in there to excise part or all of that capsule. If you
Because that's what's making the oil, right, Nate? Because
Yep.
if you don't get that, it's going to just kind of fill back up again. That's why you want to get that. Is that correct?
Correct. Absolutely correct. Yeah, if you didn't, much more likely to recur. And by the way, that should be on every single consent form that you do for these procedures anyway, is, I can't guarantee that this little lump or bump won't come back. I told the couple of patients this afternoon, I can't guarantee they won't come back in 6 months or 6 years. They're probably never going to come back, but you need to understand that any lump or bump can come back or regrow. So there, I understand. And if it comes back, we'll remove it again. Look at that capsule, removing capsule there. So, all right, I'm going to move on to make sure we get to other procedures here. Any final questions on eyelid procedures? By the way, here's what he looked like before. Okay. You can see the, 3 or 4 lesions there. Here's what he looked like immediately coming off the table. And again, students did 95% of this. Removing these lesions, it's going to be a little bit red. It's going to be a little bit irritated. You're going to put some ointment on it. Everything heals better when it's moist. So before, immediately post-op, and a 3-week follow-up. And I would charge that you can't even see where we removed those lower eyelid lesions. That's what you guys are going to do for your patients. You choose them wisely. You do those easy ones first. You get some confidence. Again, students did the vast majority, and that's here's one of the recent ones. This is a 31-year-old came with a huge cyst. I don't have time to show the video, but man, that thing drained cheese forever. Okay. All right. I do want to show this is a quick video, biopsy. What's the difference between a lesion removal and a biopsy? You threw the specimen in the biopsy container. That's the difference. Okay. It's the same thing. It's the same process. You're going to numb them up with local anesthesia. You're going to betadine clean the area. You're going to remove a portion of this lesion. In this case, I was like, I think this is a papilloma, probably a skin tag papilloma, something like that. But you know what? Let's just make sure this isn't a weird atypical basal cell or squamous cell. Here's the biopsy. There's a Westcott scissors. And could you do this? Start of the procedure. End of the procedure. That's it. That is an incisional biopsy. It's not an excisional biopsy where you're controlling for clear margins, something like a Mohs procedure or things like that. That is an incisional biopsy. You took a piece of this to identify what this is. That's all you're doing. I'm not taking all of this. I took a piece of this to identify what is this lesion, an incisional snip, or you could call it a shave biopsy, little Westcott scissors. Again, you could have used a scalpel. You could have used radio frequency. Take that piece, throw it in the cup. That's the difference between a lesion removal and a biopsy. You threw it in the cup, the biopsy cup, and the biopsy came back squamous papilloma benign. Squamous papilloma benign. Awesome. Wonderful. We feel great, Mrs. Jones. It's completely benign, and we will remove the rest now that we know what this is, and you're completely happy. So there we go.
Hey, Nate, a question came in. What is the post-procedure protocol? Do you use an antibiotic ointment, antibiotic steroid ointment? What do you use?
So for these standard lesion removals on the eyelids is a standard antibiotic ointment, a erythromycin, your favorite bland antibiotic ointment, and it's really more about the moisture. Everything heals better when it's moist. So we use erythromycin. Mrs. Jones used this 3 times a day until the tube runs out for the next 10 days, and that will facilitate this healing. So standard antibiotic ointment. I only deviate from that on chalazion, incision, and curettage. So it's chalazion INC. I do a combination antibiotic steroid. I still want the antibiotic and the moisture in there, but I like a little bit of a steroid in there to minimize inflammation, chalazion, and inflammatory bump as well. So that's what I use in the post-op. Any other questions on eyelid lesion removal?
Nope, we're good for now.
Okay, I am going to move on to, well, let's do a polling question. How about that? Should we do? Let's launch our first polling question.
Polling number 1. All right.
I believe it says how many states currently authorize optometrists to perform laser procedures, right?
That is correct.
And well, actually, can we do both of them, 1 and 2, Joe? Because the second question, can we do both of them right away?
Yeah.
Second one's how many states authorize optometrists to perform eyelid procedures, injections. So we covered both of those at the start. And I'm going to, so there's polling number 1.
Mm-hmm. They're rolling in.
Okay.
All right, so we're slowing down, so I'm gonna close poll, and the vast winner for question number 1, how many states allow laser procedures? It was 14.
There we go. All right, let's launch number 2. Polling
Number
question number 2.
How many states currently allow optometrists to perform injections in the eyelid and perform eyelid procedures, lump bump removal? And I think we're slowing down here. And again, the vast winner was 20.
There we go. Awesome. Okay, so speaking of those laser procedures, let's watch some capsulotomy. You guys can see my screen, right? Video of a cloudy capsule.
Yep.
The number 1 laser procedure, I say again, remember this, the number 1 laser procedure that optometrists perform across the country is YAG laser capsulotomy. And it's an incredibly rewarding procedure, an incredibly helpful procedure for our patients, using a YAG laser. Okay, obviously on the back of the capsule, posterior capsular opacification. And there's a number of settings that we'll discuss in the next 3 or 4 videos of YAG capsulotomy. And there's a number of different ways that you can do a YAG capsulotomy. You are watching the cruciate pattern, or the modified cruciate pattern here. You can see our 2, kind of focusing beams. This is not a great video, by the way. It's not a great video. But there's a reason I show this as one of the early videos, because this was a very agreeable capsule. Watch as we do the cruciate pattern. Went down the vertical meridian, now going to the horizontal. And move this to, this is the best part. Look at the two beams. You bring those 2 beams together on the posterior capsule, and look how these flaps just fold back instantaneously. If you do a cruciate or a cross pattern, meaning going straight down the vertical meridian from 12 down to 6 o'clock, and then you go in the horizontal meridian out to 9 o'clock and out to 3 o'clock, you can make sense. You're going to have 4 flaps, right? You did a cross, you're going to have 4 flaps. And sometimes the capsule is very agreeable. And those flaps fold back and fold back and fold back and fold back. And this is going to be a typical 20 or 30 shot capsulotomy. Sometimes they don't fold back. And then you got to use the laser energy to shoot, and move that flap back, and shot, and move this flap back, and shot, and move that flap back. And it may take 40, 50, 60, 70 plus shots to do a YAG capsulotomy. So this is a very agreeable capsule. At this point, once we've neared completion here, you're going to ask yourself, did I clear the visual axis? And the answer is yes, we certainly have cleared the visual axis. And is my opening at least as big as the undilated pupil in dim illumination? On the pre-op, before we dilate them, we note what's the undilated pupil in dim illumination there. So easy, quick, first YAG capsulotomy. Let's watch another one. This is one of our students that graduated in 2021, Dr. Claire Keating. She's doing her second YAG capsulotomy. This is like in June of her fourth year. So it's the start of the fourth year. There's the first shot. And there's the second shot. Look at that nice opening. Then she got a bubble in the laser lens with the gel. So she took the lens off and put the lens back on. That's what you saw there. But there's the 2B. Here's shot number 3. Look at that opening. We're going down the vertical meridian here. Again, this is a YAG laser. It's a YAG laser, which is a photo-disruptive laser. And we're going to dial in the energy, somewhere between 1.5 and 2 millijoules. And we're going to dial in the offset, which is usually about 250 microns of posterior offset, which I probably don't have time to go into tonight. And we're on single pulse. You can see good view of those 2 beams. Look at that cloudy capsule, vision's down 2030 or 2040 or whatever it is, and opening up this cloudy membrane. And Joe and Greg know this. What are the skills to do a YAG capsulotomy? As this student is doing this YAG capsulotomy, what skills are they utilizing? Their eyes are
they're using their slit lamp skills.
Exactly. Their eyes are behind the oculars. Their hand is on a joystick. You move an illumination tower one way or the other. You started training for laser procedures your first year of optometry school. You probably didn't realize it because I didn't realize it either. But when you started training on slit lamp, you were starting your laser procedures journey because doing a YAG cap or an SLT or a PI is all about slit lamp and lens skills. What are your skills with a gonioscopy lens? When you're specifically when you're doing an SLT. Yes, Greg.
Not to belittle it, but foreign body removal versus a YAG cap. I think foreign body takes a little bit more skill.
Sure.
When you're doing it behind the microscope, you've got patient blinking, squeezing. Here you got a lens on the eye, you're focusing. Don't want to belittle, obviously, a YAG cap, but I think if those that are doing foreign bodies, you could probably morph right into a YAG capsulotomy.
Yeah, you're absolutely right. It's always seemed a little backwards to me, Greg, that there's more states that authorize a chalazion incision and curettage, the 2021 states now with Minnesota, than authorize you to do an SLT. Because I promise you, there are more skills needed, more of a learning curve to do a chalazion incision and curettage on the underside of the lid than there is to do an SLT.
Absolutely. Yeah.
So again, you guys focus on the capsule all the time. You certainly have to know what you're doing. You have to understand your laser settings, the energy and the offset and things like that, and know where you're at. But this is a procedure that you could pick up very quickly if you so desire, and your optometry law allows it in that state. As this nears completion, Dr. Claire Keating, again under my supervision for this one. This is a 26-shot capsulotomy at 1.5 millijoules per shot, for a total energy of 39 millijoules into the eye, which is perfect. Most capsulotomy procedures are accomplished somewhere between 20 and 60 shots. Somewhere between 20 and 60 shots for a YAG capsulotomy. What's fun about these is everyone is different. You take a look at this one, you can see kind of the vertical tension lines. You can see the kind of that tension in this posterior capsule. This patient was 20/30 minus, 20/40 plus. This is me doing this one from about, I don't know, 2016, 2017, 2018. Actually, a couple of docs from North Carolina brought in one of their state legislators as North Carolina was making a strong push in 2016, 2017. It's actually had I had a legislator behind me watching me do this procedure. No pressure or anything like that. But this is, again, a great video, an agreeable capsule. I did the horizontal first. Why did I do the horizontal first? Because those vertical tension lines, this capsule kind of wanted to pull apart in this direction. And you take a look. Which flap is your favorite? I like the top right flap the best. Look how that top right flap, I'm going to rewind this here just for a second. As you look at this and as we complete the cruciate, again, we did horizontal first and now vertical. Watch how the top right flap folds back beautifully. And the bottom two flaps are kind of just staying stationary there. And they just need a little assistance. They need a little encouragement from a couple of laser shots here to get these flaps to fold back. Again, did we clear the visual axis? Did we make our opening as large as it needs to be? You know, that's the thought process here. This patient went from 2040 plus to 2020. 2020, you know, to standard capsulotomy here. No pits, no issues with this one. Very quick. That was actually 90 seconds from first shot to last shot. 90 seconds, first shot to last shot. That's what you guys will do for your patients. Okay.
Nate, do you take into account the pupil size before, maybe starting the procedure, smaller pupil, noting how, larger pupil, how big to make that capsule?
Yep.
Yeah, capsulotomy.
Yep, absolutely. You note the undilated pupil size and in dim illumination before we dilate them. And if you can make a small opening, if they have small pupils, you could potentially make a smaller opening. The golden rule of lasers is use the least number of shots at the lowest energy to accomplish the desired result. So a smaller opening obviously would require less shots. That being said, you still need to you evaluate the posterior pole, so that patient that needs a capsulotomy, make sure your BIO has good views down the road. So we typically make our openings approximately 4 to 6 millimeters in size, 5 to 6 millimeters in size for most YAG capsulotomies. How about this one, guys? You ready? Look at this. Woo! This patient came in hand motion. Hand motion. This is a patient actually in their 50s. In their 50s. Had cataract surgery 19 years ago. Was in a traumatic a bar fight and had a traumatic cataract and had cataract surgery in his 30s. And vision just slowly deteriorated after that. And he thought the cataract grew back and he didn't want to have surgery again. And his vision in the other eye was just fine. So he's been living with hand motion vision for a while. Finally went to see an eye doctor and said, we can probably clear this up for you. So watch this capsulotomy. Every laser manufacturer is a little bit different. If you're wondering why some of the beam, there's the first shot right there. And second shot. Some laser manufacturers have green focusing beams and some have red focusing beams. So it just depends on the laser manufacturer. This is actually me doing this one. The student beforehand said, Dr. Nate, I think this is more than I can handle. Will you go ahead and start this? And I said, sure, I'm happy to do that. And I said, just tap me on the shoulder when you're ready to take over. Okay. So I'm like, great. So just tap. And you'll notice I did the vertical meridian and like nothing happened. This is like firing in slushy, sludgy, soft slush, basically. I've taken 10 shots in the vertical meridian and 10 shots in the horizontal meridian approximately, and nothing has happened. But I'm like, whew, there's still this soft, mushy stuff there. So I'm like, buckle up, here we go. This is just going to take a lot of shots to clear and break up this thick, mushy capsule. Instead of 1.5 millijoules per shot, I was at 2.3 millijoules per shot.
Now, Nate, would agree that there's probably still a little bit of, maybe they didn't clear all the cataract out, maybe just a little bit more than just capsule in that one?
Yep. I debated, was there a little bit of cortex in here? It's hard to say. If this would have been 6 months after cataract surgery, I'd have thought, even stronger on that. But man, it was 19 years ago. But yeah, this is just, it almost
I think
acted a
there's
little
some
bit.
cortex there. Yeah,
Yeah, I think so
I think
too.
so.
That you are watching a 220 shot capsulotomy at 2.3 millijoules per shot. Again, not a typical one. What did I tell you guys? The typical number of shots for a YAG capsulotomy is usually where? Kind of 20 to 60 shots, somewhere in there. But you know what? Sometimes it takes more. Sometimes it just takes more. Might this patient complain of some floaters after this procedure? Yeah, they might have some debris floating around there. Joe, any questions that we have coming in as they're watching this with the YAG capsulotomies? I don't know if he's muted or if I can't see him there, so I didn't hear
Sorry
him
about
say anything.
my dogs are barking. All
Ah,
right, so no questions, but something that you may want to share. Is there a visual acuity or glare requirement in order to justify a capsulotomy?
there is not a visual acuity or glare number to justify this. It is activities of daily living. You can do a YAG cap if they're 20/20, and yet, man, doc, the glare is bothering me, or for this reason or that reason, but there is not a number, meaning they got to be 20/25 or worse, or, they got to glare to this point. You have documented a functional complaint that you are attributing to obviously PCO, and doing a YAG cap will improve their complaint, so improve their daily living. So you document activities of daily living are affected.
So a question did just roll in. What happens that results in a lens pit?
What happens that results in a lens pit? That means you missed anterior. I'm focusing here on the posterior capsule, and there is a little explosion of YAG energy. Okay, it's a little acoustic shock wave and a lot of it travels actually anterior. You heard me earlier say there's an offset button, so you actually focus on the posterior capsule, but I dial in 250 microns of posterior offset. So I'm focused on the posterior capsule, but you know where my little YAG explosion starts? 250 microns behind, because I have 250 microns of posterior offset. And that explosion comes forward and it hits the posterior capsule and it leaves the IOL alone. If you are focused too far anterior and some of that YAG energy goes into the IOL, that is going to cause a lens pit. So when you guys see lens pittings, it means the optometrist or the ophthalmologist that did that YAG cap missed. They missed the posterior capsule, and some of the YAG energy went into the IOL. So they missed anterior. Okay. Speaking of pits, I just got a tap on the shoulder. Remember, I told you the student was watching me, and they tapped me and like, Dr. Nate, can I take over? Sure, sure. You can do this last part here. Okay. So I want you to watch closely. So this is a fourth year student. There's the first shot. And notice you see your desired tissue reaction. Wonderful. Tissue capsule is reacting. Watch closely. And Joe or Greg, you'll have to let me know if you guys can see that here. Notice I rewound, reacting, reacting,
Mm-hmm.
reacting, reacting. Could you see the pit right here? Can you guys appreciate that or not, Joe?
Yeah, we're good. Yep.
Yeah. Mm-hmm.
Yep. So I'll rewind it again so you guys can see it in real time. Look very closely. That is a lens pit. That means, again, the energy was focused too far anterior. Good there, good there. I think it's this shot right there. And you can see a little ding, a little nick in the lens. So, yep, that is a lens pit. Okay.
Do you find that acrylic lenses versus silicone lenses pit easier than the other?
Oh, silicone lenses pit much easier than the acrylic. And our main silicone lens is going to be the light adjustable lens. So, we absolutely modify a couple of things in the light adjustable lenses or the silicone lenses. We actually will decrease our energy, so the explosion is a little less, and we actually increase our offset by like 50 to 100 microns. So instead of doing a YAG cap at 1.5 millijoules with 250 microns of posterior offset, I might do it at 1.2 millijoules from 1.5 to 1.2 and make my offset like 300 or 350 microns of posterior offset because silicone IOL's just easier to pit.
Couple questions came in, Nate. I think we can probably do them. When you do a YAG, doesn't that locks you in? You can't do an IOL exchange at that point, correct?
That is absolutely correct. If you, I always tell docs, around the country, if you don't try to be the hero a month after premium IOLs or 2 months or 3 months. You have an unhappy patient and you think, well, maybe it's the trace PCO. And I'm going to do a YAG cap when in fact they just are not handling their IOL well, whether it's a multifocal premium or whatever. When you do a YAG cap, you've pretty much eliminated the opportunity to take out that lens and put in a different one. So you make sure that that IOL doesn't have to be explanted. So again, if it's 3 years later, probably not. But if they're in that 1 month, 2 month, 3 months, up to 6 months, just be cautious with that because you have absolutely removed the opportunity in the window to remove that IOL.
How soon after cataract surgery can the late YAG be done?
91 days. How's that? You guys know why I said that, didn't you? 91
Yeah.
days. You can do it at any point if there's a functional complaint. I think a lot of surgeons are probably going to wait until they're outside the global period for cataract surgery, which is 90 days. That's why I kind of jokingly said 91. I have rarely done it where or patients they needed a YAG cap at day 60 or whatnot. Just for whatever younger patients tend to develop it quicker and they grow more of this PCO. But generally speaking, you're going to probably wait until they're outside the global period for cataract surgery. But it can be done at any time.
And what about the circular procedure for the cap? Any comments on that?
Yeah, that's the number two. The circular technique. Is that what you asked about?
Yeah.
Yeah. So the number one pattern is the cruciate pattern. Ophthalmology surveys show it's more than double the next most common. The circular pattern is the second most common. And it really is surgeon preference on whether you do the cruciate, the circular, there's a star pattern, there's a postage stamp, there's a tuna can lid or a bucket, there's all kinds of them. But circular and cruciate are clearly the top two. Some would argue that maybe you want to do the circular in premium IOLs, the Crystal lens back in the day when that was more popular. But at the end of the day, it really is surgeon dependent on whether you're doing the cruciate, the circular, or another pattern.
Now, the final question we have right now is what's the maximum energy millijoules you'll use during a YAG procedure on a dense PCL?
That's a great.
We bring back for a second procedure instead of trying to do it all at once?
So multiple answers for that one. I'll give you. I was trained to kind of take stock moment at about 150 millijoules total energy in the eye. So once I got to about 150, I went, all right, why is it taking me more longer than it should? Most capsulotomies are 20 to 60 shots at about 1.5 to 2 millijoules per shot. Well, if you do that math, 50 shots at even 2 millijoules per shot is only 100 millijoules. So you're not approaching that 150. But I was trained about 150 millijoules. Maybe we should bring them back in a week and redo that, and not redo it, but do the second part of the procedure a week later. That being said, if you ask your ophthalmologist, what's the maximum amount of energy that you put in the eye in any one visit? You know what they're very, very likely going to say? Until I get the job done is the answer that they're going to say. And that is truthfully my answer now is until I get the job done. I'm going to, this is a thicker one. You just watched a video of a 220 shot capsulotomy at 2.3 millijoules per shot. Well, you add that up, that's over 400 millijoules total energy in the eye. I'm going to go until I get the job done. But on your early cases, maybe you kind of think about it about 150 millijoules. All right, we're gonna move on. Any last
Nate,
questions?
I got a couple questions. Are there any
Yeah.
optometrists doing bilateral procedures? I know ophthalmologists are just because they're so busy, and they'll take the hit on the second one because it's the same day.
Yep.
Do you know of anyone doing that? And then The other question is, do you have any video of any anterior phimosis where you're lasering that?
The video, while you were asking that question, Greg, I went, well, while we're answering these questions, I might as well show an anterior capsulotomy. So here is anterior phimosis. Okay, this is actually, we did a posterior capsulotomy and an anterior capsulotomy in this one. Okay, if you look closely, look how this patient. So yeah, there's kind of a membrane. You guys see this kind of membrane going across an irregular anterior capsule and kind of this membrane. So we'll watch an anterior capsulotomy here. So this is pretty rare. This is going to be, 1% of your capsulotomies. 99% are going to be posterior capsulotomies. This is still the posterior capsule here, but I'm going to shift to the anterior in just a second. But yeah, if you ever see a patient that has anterior capsular phimosis, that contraction of the front of the capsule, you can do an anterior capsulotomy. So I will change the offset from a posterior offset to an anterior offset. And there's a number of different ways that you can do this. Okay, you can see that kind of membrane growing across there, that kind of sheen growing across. Greg, what was the first question?
Bilateral.
Bilateral. I have done about thousands of capsulotomies, and I've done a handful of bilateral, and it strictly was patient how far away they came from for the procedure, and they understood the risks of the rare, bilateral procedure if they developed bilateral retinal tears, which is a rare risk with this. So, I've done 4, 5, 6 of them, but as optometrists, our complications are judged differently than ophthalmologists. And I'm not saying it's right, but our complications will be judged differently. I would encourage optometrists to not do bilateral YAG caps unless maybe you've got hundreds and hundreds and hundreds and hundreds of procedures under your belt. But I would encourage you to do one at a time. That's my personal preference. There are ophthalmologists that do both.
Thank you.
2 shots left. Watch this last shot. It's pretty cool. Watch this membrane go ding all the way across, and there's an anterior capsulotomy there. So a lot of times you'll want to do kind of a radial pattern when you're doing these. I don't know if I have it in this deck or not. See, this is all the kind of the advanced stuff that we don't have time to get into. Hold on. I don't have it in here on this one, but you could with the radial pattern with phimosis, you'd kind of just make radial slits to just break that phimosis up. So, any other questions on YAG capsulotomy?
Well, let's
Steroid
see.
use following it, post-op?
Say again?
Post-op, any steroids?
I was trained to put them on a steroid. I put them on post-op steroids, your Pred, your Lotamax, 4 times a day for a week. I no longer do that because surveys show 80+% of ophthalmologists don't even put them on a steroid post-op. So I no longer use post-operative steroids after a typical YAG capsulotomy. The atypical ones, like the 230 shot, then I'll put them on a steroid. But for a standard YAG cap, I do not use post-op steroids. I do use post-op steroids for PIs and SLTs.
How important is it to know? Oh, good, Greg.
No. Go ahead and do that, and then I'll do mine.
How important is to know the material of the IOL? Because you may not know what it is if you're not the surgeon or if you don't have the records.
Yep. Yeah, and you may not. I mean, it is not absolutely critical. I mean, your biggest risk would be lens pitting. If it was a silicone IOL and you didn't know it was a silicone IOL, you might go, oh, I'm at 1.5 millijoules with 250 microns of posterior offset, and the first couple of shots caused pitting when it normally wouldn't. Is this a silicone IOL? And that's why you're going to start with your capsulotomies not in the visual axis. You're going to start, I start up at 12 o'clock, whether it's the cruciate or it's the circular, you're going to start up at 12 o'clock. And if you put a couple of pits in right away, well, then you're going to adjust something at that point. You're going to decrease your energy or you're going to increase your posterior offset. So it's not critical. I would defend anybody that did a YAG cap without knowing exactly what the lens is. It is not part of my routine pre-op to ask for the card that they get from the cataract surgeon of what the IOL material is.
It's definitely helpful, but I wouldn't say critical. And maybe if you're just starting off, it might be helpful just to kind of,
Yep.
know what you're up against there. My
Unless it's an
question was going,
LAL, it's most likely going to be acrylic. Most likely, unless you have an LAL or one of those. Yep.
then my question was going to be, do you bring them back within a month and dilate and check out that posterior pole?
We bring them back in 1 week. You could do 2 weeks. The global period is 90 days for a YAG capsulotomy. So it's a 90-day global, just like cataract surgery. We bring them back in a week or two, and we will take a look undilated to make sure I don't see any flaps of PCO in the undilated pupil that need to be touched up. So we take a look undilated in the pupil. Usually you can't see anything because you've opened up the capsule nicely, but then we will dilate them at that same visit and make sure everything looks nice and hunky-dory in the back of the eye. Any other
Fantastic. Thank
questions?
you.
All right, let's launch polling question number 3. Joe,
right.
what is the most commonly performed laser procedure by optometrists across the country? We may have just talked about it for the last 20 minutes. YAG cap, LPI, SLT, or laser floater removal? Most commonly performed laser procedure. It is a clear
Okay.
number 1.
It's open. People are responding. I think we may not go very long on this one. I think it is pretty straightforward.
Joe, Greg, remind me again. I did a webinar for you guys actually on laser floater removal, correct?
That's correct.
When was that again? Was that in 2025 or 2024?
It was
25.
probably 2025.
Okay.
It was not that long ago.
Okay. So I'm not going to spend a great deal of time on this because we just did that webinar. They can go back and watch that, can they not?
They can.
Okay. But it was the number third most common answer. So I'm going to spend maybe just 5 minutes on this and show you a couple of videos of laser floater removal.
And
Okay.
for the poll, everybody, most people got it right. It was the YAG cap.
Okay. So YAG laser vitreolysis, laser floater removal. This is something that I started doing in 2019. So I was 10 years into my laser career with thousands of laser procedures under my belt, capsulotomy number 1, SLT, and then PI. And this is something that's within our scope of practice in Oklahoma. And I was really looking for something to help our floater patients in between do nothing observation and a floater only vitrectomy. And that's a pretty wide gap in between pat them on the back and do nothing and a floater only vitrectomy, which many patients don't want to have, even though it's getting to be a better and better procedure. That's a wide gap. So, as Paul Singh and Carl Stonecipher and numerous ophthalmologists were kind of lecturing more on this and doing this more, and they helped to train me on this procedure of basically using a YAG laser. It's the same laser, and instead of vaporizing and opening up the capsule, you are vaporizing the floaters that are bothersome to the patient. And this is the ideal candidate. The ideal candidate is that patient that has a Weiss ring, a semi-Weiss ring. I'll call it a Weiss component, whatever it is. But they go, Doc, I got this bug in my eye. I had a patient yesterday afternoon that said, Doc, I got this one floater, and it just drives me crazy. It's right here. It's kind of semicircular, and it is driving me nuts. It's been there for like 3 years, and I don't want to observe it. And I go through all the options. Every single patient, I give them the option of monitoring. We can just watch this. Or we can laser and break up and vaporize as much of this floater as possible. Or I'm happy to send you to a retina surgeon for a floater only vitrectomy. Those are kind of our main 3 treatment options. And boy, if you choose your patients wisely, the floater's been there for at least 6 months. And the symptoms match the signs. Meaning, if this patient, Joe and Greg, complained of strings and strands and cobwebs everywhere, well, that doesn't match that at all, does it?
Correct.
So you got to match what they're telling you, what they're describing you as best you can to what you're seeing. Do the signs match the symptoms? The best example I can give you is I had a lady last spring that said, Dr. Nate, I have got the state of Florida floating in my eye. She said, it is the state of Florida. Like, and I look back there and sure enough, it is the state of Florida that is floating in her eye. And makes sense. So like when we use the YAG laser to vaporize of as much of this as possible, she's going to do much better. That's so match their symptoms with the signs. It's been there at least 6 months. We've given them the opportunity to neuroadapt to this. It's a safe distance. Yes.
I was just going to say, I think I should try and find this for you. I had a patient come in and had this Weiss ring, a couple little tentacles, a little diamond shape off of it. And she drew it exactly kind of like in a reverse image.
Yeah.
And I took a picture of my camera. That would have been the perfect one, the laser, because it was amazing how she drew it exactly. And when I took a picture of the floater, it matched it exactly.
Matched it perfectly. You guys are I'm gonna hold on. I know I'm pulling up some files here, but you guys are the first group to see this. I just added. You can see I updated this at 8:01 yesterday morning. This is the where's that at? It's this one right here. The most recent YAG vitreolysis. You guys see the screen there?
Yep.
Mm-hmm.
And again, Doc, there, you can see it there. I got this. Just is it bothering me, Doc? This, yeah, and you're matching their symptoms with the signs. Now, look, remember this. Remember what this looks like, and watch 1 minute later. This floater behaved. It sat there, and it let me. And again, this is going to be watch. Boom, boom, and you can see. And now I'm going boom, boom. I always do 1 or 2 test shots. All right, this is what we're going to do, Mrs. Jones. You saw I fired it singly the first and second shot, and then after that, it is. Boom, 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 boom. All right, now we're beating this thing up. You're vaporizing this. Look, those are all vaporization bubbles. And boom, 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 boom. I'm a mile from the retina. How do I know I'm a mile from the retina? Because the retina is blurry. When the flow, see, there's retina. Now I always check where are we at? There's retina. Back to look at that. There's retina. And that floater, there's retina. You have spatial awareness. You never fire if the retina is in focus there. Again, that's what it looked like at the start. I did not edit this video. This was literally one of the easiest ones I've ever done. And a minute later, that floater's gone. We have vaporized that. Okay, we've vaporized that. So, all right, what else do we, that was the floaters here. We'll watch one more video here. Retina, don't fire thou. Where am I at in this ocean of vitreous? Where am I at in this ocean of vitreous? Making sure you're in a safe location. Now, as you watch this last video on laser floater removal.
Hey, Nate, what type of laser are you using?
It's a YAG laser. It's the same exact laser. It's a YAG laser. YAG laser capsulotomy. YAG laser peripheral iridotomy. You're watching YAG laser vitreolysis. It's a YAG laser. So the
different
same
lens than you're using for YAG cap, or you get a little deeper, or is it the same lens?
I use the Singh mid-vitreous lens, named after Dr. Paul Singh. He invented the mid-vitreous lens. So I use that gives you your best view of the middle to posterior vitreous.
So the lenses will help keep you in a safe range too. If
Yep.
not saying you can't get out of towards the retina, but again, like you said earlier, if you have the right tools, you can do this.
I recommend, this is definitely the most difficult of the four. Would have the most significant consequences if you were to miss, posterior especially. I think you should probably have hundreds and hundreds and hundreds of lasers under your belt before you venture into laser floater removal. There certainly is, this procedure is not without controversy, is not the right word, but I know there are ophthalmologists that are against this. Many in the retina community are against this, but there's many ophthalmologists and more ophthalmologists that are doing this as well. So
it's more criticism than controversy, I would say.
Yeah, yeah, that's a good word, Greg. Yeah, more criticism. But I'll tell you, you choose your patients wisely and you explain all the options and you make an informed decision together. This is a wonderful procedure. My sweet spot is between 50 and 90% floater improvement. It's really probably 60 to 90% floater improvement. So I tell them that, it's hard to get all of the floater. It's hard to vaporize everything. You can't do that. So my sweet spot is 50 to 90% floater improvement. I would say, Mrs. Jones, if we could make your floater 70% better, you probably would take that. But if you tell me, Nate, I want 100% floater improvement, then we're going to go to option number 3, which is a floater only vitrectomy. It's exactly how I phrase it to patients there. So choose your patients wisely. Okay. I mean, you just look at, I'm not going to show this video, but you just take a look at this, guys. You think these patients are miserable? Get the focused on this. I mean, look at this floater. And again, you have many patients that are asymptomatic from floaters. That's not a candidate. If they're asymptomatic, that's why I don't do these in the first 6 months, because sometimes they neuroadapt to them, but sometimes they don't. How many of you have some patients that are symptomatic from their floaters? If it's the right type of floater, it's a possible option there. Okay. Any last questions on laser floater treatment? I have a summary slide here. I'll leave it here. Any last questions, Joe or Greg?
Nope.
Okay. What do we got? About 20 minutes left. Is that right?
That is correct.
Okay. Let's go back to where were we at here? Yep. Okay. Want to show, trying to remember what our number one, let's go back here. So we covered eyelid lesion removal and biopsy. We covered YAG cap. We covered laser floater removal, SLT, and trichiasis. I want to make sure we get to our questions. I want to show a couple of new things here in our last 20 minutes. Where's my video at? Oh, yeah, it's down here. So I want to talk about the plasma pen. Okay, this is something new that I've done in the last year for conjunctival chalazion, CCH, redundant loose conjunctiva. We have a plasma pen that helps to, through the use of plasma technology, shrivel up and shrink that conjunctiva without making incisions, without surgery. I've, chatted with Dr. Laura Perriman. She's an ophthalmologist in Washington that is big on this. You can treat bulbar and palpebral conjunctival cysts, but it's the use of a plasma pen to help reduce that redundant conjunctiva. Okay.
And just so everyone knows, that's the inferior fornix at the top. The head of the patient is down at the bottom of the screen.
Good. Yep. Good call, Greg.
Just to help orient the audience.
We have a surgical microscope, so the patients are always laying flat, so we can video these procedures. This patient had a combination of CCH as well as a couple of bulbar conjunctival cysts, and that's what we're treating right there. Okay, is these bulbar conjunctival cysts. How often do you guys see patients that have a little bit of redundant conjunctiva, a little bit of extra conjunctiva, those folds along the inferior lid margin that may be flopping onto the lid margin? You're not going to probably see it every single day. But if you have a patient that's complaining of dry eye symptoms, foreign body sensation, maybe a little bit of tearing and things like that, we have a nice treatment option with what's called a plasma pen. And you can see in this video, and this is only topical numbing. This is not an injection. You wouldn't want to do a subconjunctival injection of lidocaine because then it balloons up the conjunctiva, which is what you're treating. And I usually do a grid pattern, which you'll see a little bit later in this video. But we're going to numb them up with proparacaine. You could consider tetracaine. I do use 4% topical lidocaine on a Wexel, a surgical spear sponge. And you're shriveling up this conjunctiva. And again, in full disclosure, I am fairly new at this. I've only been doing this for about a year. and only have a dozen and a half of these under my belt at this point. But it's very easy. There's no injection. Again, topical numbing only. You can do this behind the slit lamp. I've been surprised when patients come back saying, I should have had this done a long time ago, Dr. Nate. My eyes feel much better. Again, when you have all those redundant folds of conjunctiva, that can impair the ability of the tears to flow as they should flow across the ocular surface and cause tearing as well. So, you do this procedure to help to minimize their symptoms. There's the 4% topical lidocaine on a Wexel. Okay. I'm going to fast forward here. So here's kind of a grid pattern here.
And just so the audience to get a little bit of pharmacology in, lidocaine is going to be a little bit different. It's an amide. It's not going to be broken down by plasma cholinesterase. You'll get a little deeper anesthesia.
Yep.
I do keep some 4% in the office if I get a really red eye, foreign body that's been in there for a week, and you're just trying to get a deep anesthesia, and you can't get it with proparacaine or lidocaine or your fluoresce because it's all being broken down by that injection. You can use lidocaine. It will give a little deeper anesthesia because it's broken down in the liver as opposed by the plasma cholinesterase. Those are esterase types of the ones that we have in our office, the proparacaines and the tetracaines.
Yep. No, so I went too far. These are the types. This is a pretty classic, again, inferior nasal, inferior temporal. You can see that redundant conjunctiva. We're in the process of treating this. This is emerging technology here. This is one of our residents was being just a little bit aggressive. They're kind of dragging it. So he said, yeah, let's, and then the patient felt it just a little bit. Notice they didn't even move. So we're putting in just another sponge there, a little bit more 4% topical lidocaine before, moving on. And I typically will do kind of a grid pattern here, kind of a different arcs. You can see we're moving outward and, just shriveling up that extra conjunctiva. Certainly they can bleed just a little bit. And again, I typically do this inferior temporal, inferior nasal. This one's getting pretty close to straight temporal here. Yeah, they can have a little bleeding here, but the use of the plasma pen for CCH, conjunctival chalasis, bulbar and palpebral conjunctival cysts. There are some, I have not done this, but there are some that are using this for mild dermatochalasis. So not only redundant conjunctiva as you're watching here, but a little bit of mild redundant extra skin on the upper eyelid. Again, I have not done that yet. Numbing up with like a lidocaine gel. This is used in aesthetics. This is in the aesthetic space as well. So there's numerous uses for that. But I wanted to just talk on for just a couple of minutes the CCH because traditionally what have we done, Joe, Greg, for CCH? It's been if it's real bad, send them to surgery. Maybe a topical steroid. Other than that, we just kind of watched it, didn't we?
Correct.
So
Nate, how much is a plasma pen?
Plasma pen's going to run you somewhere between $5,000 and $10,000, and this procedure reimburses. Somewhere between $500 and $600. So, any other questions? That's new, right, Greg? From when we did the course for you guys in Pennsylvania. So.
Well, I just got back from an anti-aging conference down in Miami. That's where I was a little bit earlier this week. And plasma pens are big at the aesthetics. So.
Yep, big in aesthetics. And I don't utilize it for that with our patients with Cherokee Nation. We just don't have the right demographics for it. But, I've really, really enjoyed having a new procedure for CCH in some of these patients. So, all right, I'm moving on. If we don't have any last questions on this.
You good?
Good? Okay.
Yep.
All right, Joe, let's launch polling question number 4. How's that?
Number 4? Wait. Sure.
Actually, it's polling question number 5. Let's hold. You can't launch 5, can you? I forgot the order.
Do you want 5?
Yeah, let's launch number 5.
Okay.
The use of the plasma pen can help with what condition? PCO, glaucoma, entropion, or conjunctival chalasis? The use of the plasma pen. And Joe, Greg, you'd have to check with your state board when it's injection free, when there's no injections.
Mhm.
Greg, is that within your scope in Pennsylvania? I don't know the answer to that, but there's no injection there.
The answer is going to be a gray area, which then allows us to kind of, in Pennsylvania, to be able to kind of, in a sense, do it. Because
Yep.
it's, because we had one of those laws where it was inclusion or exclusion. Well, when
Yep.
they wrote the law back in 2002, there wasn't plasma pens, right? So they
Yep.
didn't write in there, oh, you can't use a plasma pen.
Yep.
But we didn't write in there, you could do a plasma pen.
Yep.
So that's where the, comes in to be gray. I mean, I certainly, knowing my law, would have no problem performing this procedure in Pennsylvania. But it's, the purists are going to be like, I want to see it written. And then the purists are going to say, I want to see it not written, but it's not going to be in there because the last time we had the regulations was 2002.
Yep. So
And
would you say it's
the poll answered the vast majority, got it right with CCH.
perfect? All right, we got about 10 minutes left. I'm hoping to talk about two more procedures. Is also not, I shouldn't say a new one, excuse me, but a new one that we added to the course in the last couple of years. And this is the use of dichloroacetic acid, also known as bichloroacetic acid. Chemical cautery, basically. Chemical cautery of eyelid lesions. And there's a number of eyelid lesions that you can utilize. You're watching currently the use of dichloroacetic acid to treat a simple little papilloma. This is my take-home message for you guys. I want, and it's my passion, for more optometrists to be doing procedures safely, effectively, in whatever state that you're in. This is an injection-free way to remove lesions, guys. There is north of 35 states, 35 to 40 states that can do this because it is injection-free. And you're watching a little skin tag or a little papilloma. You can do this with verruca. You could do this with seborrheic keratosis. This is my treatment of choice for xanthelasmas. My treatment of choice for xanthelasmas. I didn't treat xanthelasmas for the first 12 years of my career. But then we, found out about this. I talked with Leo Scorin, who's a friend of mine, optometrist, ophthalmologist. And he goes, Nate, I use acid to treat these. I went, oh, that's awesome. I'm going to start treating xanthelasmas. I had a follow-up today, this afternoon, and a patient was just thrilled that his big old xanthelasmas are 90% gone from the use of dichloroacetic acid. So this is the easiest lesion to remove right here, the papilloma. Okay.
Help me out with the procedure now, Nate. Is this like a cotton tip applicator? Is this already pre-prepped? Are you dipping this like and you're touching it? Like what are you using here to apply this this chemical?
So you are looking at a toothpick there. Excuse me,
Yeah.
a medical applicator. I called it a toothpick to the company and they corrected me. This is not a toothpick, it's a medical applicator. It looks just like a toothpick. So you get a little kit and it has a vial of acid that can treat about 250 patients. And you take your little dropper and your kit and you will drop literally like 2 to 4 drops of acid in the little acid receptacle. And then you set the little medical applicator toothpick in there for like 5 seconds and it will soak up the acid and then you literally paint the acid on the lesion. Touch the lesion with that medical applicator and you turn it white. You are going to use the chemical, the acid, to chemically cauterize this. You're basically destroying that via chemical. So that's what it is. There's no injection here. Therefore, there's no alcohol swab. There's no betadine that's needed. There's not even really any post-op. You just let this sit, and it's going to fall off in the 5 to 10 days after the procedure there. So and let's make sure we get to our other video here. So that is the use of that one. We're going to go here. So this patient, we just did her little skin tag, and she's got some xanthelasmas. And you take a look at the xanthelasma here, And again, it comes in just a little kit. This is going to cost you about $3,500. It's about $3,500 for this acid kit. And again, you're looking at the medical applicator, aka the toothpick. We have dipped it into about 3 drops or 4 drops of the acid vial. Again, I took 3 or 4 drops out of the acid vial and put it in their acid receptacle, and then set the toothpick in there, and we are going to touch the surface of this and turn it white. Chemical cauterization of xanthelasma. This is my treatment of choice for xanthelasmas. Turn this white.
I know you said there's no injection, no lidocaine. Is there any sensation to the patient?
I've done a number of these now, lots of these now, and I always ask, all right, scale of 1 to 10, I want you to let me know what you feel. 99% of patients on a scale of 1 to 10 will call it between a 0 and a 2. I've had some patients, I go, 1 to 10, what is it? And they go, 0. I don't even feel it. So it's almost always between a 0 and a 2, meaning there is minimal sensation. This is analogous, guys, to cryotherapy, liquid nitrogen. But instead of using chemical acid to destroy the area, you use cold cryotherapy or liquid nitrogen to destroy the area. I have removed xanthelasmas with radio frequency. We started with the Elman unit, the Sonequence unit, but you got to do an injection if you're touching this with radio frequency. And I've removed them that way before, but this is just a really nice, efficient way to remove these xanthelasmas. And I tell them it may be 1 treatment, it may be 2 treatments, it rarely may be 3 treatments, depending on what we do here, how thick it is, things like that. Most often it's 1 or 2 treatments. The guy I followed up with today, he had some big diffuse xanthelasmas. We treated him in early November and we treated him in mid-December. And he was back for his follow-up today, and it looked very, very good. Yes, you're going to have some very mild, faint scarring that will fade with time. It's going to take a couple of months for this to heal. And it's not going to look like this for a couple of months, but what's going to happen is in the next couple of weeks, this is going to slough off, basically.
And I think the key I like is that, with xanthelasma, they can return, but I think what you're going to be able to do is kind of remove that space chemically where the potential of reoccurrence would happen. So
any lesion can come back, whether it's a skin tag that you remove with radio frequency, a cyst that you remove with a scalpel, or a xanthelasma. Any lesion can recur. That needs to be on every single consent form you do. These can recur with the removal of a scalpel. My sister-in-law had her upper eyelid xanthelasmas removed by an ophthalmologist, and he completely excised them and put in sutures, and one of them has stayed away, and one of them came back within a year. And she was actually my first patient that I did acid treatment for her xanthelasma that came back after chemical cautery. That came back after complete surgical excision with a scalpel.
I just think mechanistically this might be helping to remove that chance. I mean, I agree it could come back, but I think mechanistically, you might be helping scar and get in there and prevent that. Now it can come out elsewhere, but I don't think in this area. So.
Yeah. Any questions on chemical cautery?
Nope.
Okay, I want to have one more. All right, I've got so many PowerPoints up here. I'm like, what did I? All right, we got what, about 3 minutes left, right, Joe?
That is, we got about 5 minutes.
5 minutes. Okay, let's finish with one of my favorite procedures: radio frequency ablation of trichiasis. I bet all of you can think of a patient like this that you look at and you go, man, I have been plucking their lashes every 6 to 8 weeks for years, and there is an option: radio frequency ablation of trichiasis or dystichiasis. Again, using our radio frequency device. Again, it's now called our Sonequence device. Used to be an Elman device. This was a patient from Arkansas. We did our laser and surgery course in Arkansas, and one of the docs came up to me after I lectured on radio frequency and lesion removals and this stuff, and he goes, Nate, I'm sending a patient to you. All right, tell me about it. So I have been pulling this guy's lashes for 5 years. He's got 7 offending lashes. And I'm going to send him for radio frequency ablation. I'm like, great, we can do that. Okay, we can do that. So what we do in these procedures, okay, is we're still going to numb them up. Okay, let's go back to this video here. We are going to numb them up, a little local anesthesia. Okay, we're going to take a probe and we're going to go right down the shaft of the lash to the follicle there. That's typically 1.5 to 2 millimeters below the surface of the skin. So 1.5 to 2 millimeters, on average about 1.7 millimeters. But you take this probe and you go right down the surface, right down the shaft of the lash. And if you zap them without anesthesia, they're going to feel that. Okay. So we will put a little bolus of anesthetic down here, a little local anesthetic, and I will hold 4% topical on a Wex cell on the lashes as well. So I double numb them with a little injection and a little sponge right on the lashes as well. So we numb them up, okay? And then we use our radio frequency device on setting number 3. I don't want to cut the follicle. I want to coagulate the follicle. You wouldn't want to cut. You cut there, you're going to slice right through the lid margin. But I want to coagulate. I want to destroy that follicle so that lash does not grow back. Let me show you a procedure here. Okay, this is a great video. There's our 4% topical on a Wex cell. Little surgical spear sponge there. And in this case, we had 2, we're testing to make sure we're numb. Mr. Jones, any pinching, sharpness, or pain? Just making sure you're numb. You want to be numb, right? Yeah, I want to be numb, Dr. Nate. Yep, okay. So that's what we're doing there. All right, look, this patient has 2 offending lashes. Can you see the one right here? You guys can see my cursor, correct?
Yes.
Yes.
One here, and there's another one right here. Okay. One of these lashes is made for a right-hander, and one of these lashes is made for a left-hander. Well, I'm right-handed, and I tackled the left-handed lash first, or made for the left-hander. So watch this. Again, they're completely numb, and zap, didn't get it. And you want the ideal outcome here is for that lash to stick to the probe. Okay, zap, missed it again. And again, they can't feel anything there. He's numb, but I'm sending coagulation energy. I want to coagulate that follicle. You can try to match the orientation of the probe to the lash, which I'm doing about a C- job on this one. I'm like 0 for 7 right now. And be patient with this procedure. This should not be your first in-office procedure. This should not, but this is a nice option. All right, here we go. So I'm not matching. I'm like 0 for 8. And I'm like, what am I doing with my life right now? That's what I'm thinking to myself. I'm a failure. I'm 0 for 8, 0 for 9. I'm like, oh, come on. Be patient with this. That's a small area. That is a small area to try to get this probe right down to that follicle. Now I'm like, all right, focus, Nate, come on. And watch how I subtly will move the lower lid, because remember, I'm sitting at their head. I move it kind of to the right, and now I'm better matching, and watch this. See how it sticks to the probe? We have just coagulated that follicle. So I was like 1 for 11. Okay, now watch this one. Made for my right hand here so that I can just easily match the orientation of the probe, and 1 zap, and that lash is gone. Okay. Radio frequency ablation of trichiasis. It's a great, great option for those patients that just have pesky lashes. You repeatedly epilate them, and if you want a more permanent fix, you can do this or send to somebody that has this. I'm going to let this video play for the next couple of minutes. You guys can see those lashes stick to the probe. Any last questions, Joe?
Nope, nothing's come in. We're good.
So, Joe, Greg, your thoughts?
Nate, I got a question on the one you're doing right now.
Yeah.
There looks to be a little bit of maybe some atrophy going on, with in this lid margin area. Is this from like a trauma or?
Yes. This is a patient that had
chalazion removal or
herpes zoster in the past with some scarring and a lot of, post-herpetic stuff, and years ago, nothing active, but that was part of the reason.
Okay. Because if they didn't, I would maybe be a little concerned, but that
Yep.
certainly then okay, perfect.
Again, not a first procedure. This is one where you need some decent magnification as well as you're doing this procedure. They're sticking to the probe. Joe, you want to launch that fourth? I think it's the fourth and final polling question. The use of
Poll number 4, okay.
dichloroacetic acid, chemical cautery, can be used to treat which condition? What did we just show videos on with that acid? It's my treatment of choice for which of the following lesions? You get not the procedure we were just watching, but the one right before that, the use of that chemical cautery, that acid. It is my treatment of choice for which one of these? Joe, Greg, please don't use the acid for conjunctival chalasis, right? That would be a bad idea.
Correct.
That would be a bad idea.
Well, you got your point across because virtually everybody is saying xanthelasma.
There you go. All righty.
All right. Well, if we're gonna wrap this one up, are you all done there, Nate?
I'm done. Yep.
All right. Well, I'm gonna share my screen. All right, all right, all right. So the red dot has popped up. Nate, I want to thank you. I thought it was very fascinating, a great show and tell type of presentation. I thought it looked terrific. You've really impressed a lot of people from the comments. So I want to thank you again for sharing your expertise with us.
My pleasure. Thank you for the invite. I always love to be hanging out with you guys for a couple hours.
Yeah, we love it too. Well, you can see the little red dot has come up, so you can start doing the survey. We certainly appreciate you all doing that. So this was optometric surgical procedures and injections for every optometrist. Nate, you made it look easy. I know there's a lot of skill involved, and you put a lot into learning this trade and craft and teaching it. So really appreciate you showing that and sharing that with the audience.
My pleasure to be here. I want to encourage all of you, wherever you practice, keep pushing forward, incorporating procedures where you can, where you're comfortable, where your law allows. Remember some of those things that are injection free. Maybe you didn't know about those before, to possibly help some future patients. Again, effectively, but also safely.